Thank you for participating in our second public webinar. The topic today is going to be about dry eye diagnostic. Before we start, I would like to introduce myself. For those who don't know me, I'm Daniel Rechberger. I'm a sales manager here at ESW Vision, and I will be your moderator today. I would also like to welcome our CEO and President, Petra Bruckmüller. She is going to introduce the topic. And then, moreover, I would like to welcome our special guest today, Erik ROBERTSTAD. Erik ROBERTSTAD is an outstanding optometrist who is also part of specialized dry eye networks. He's always interested in the latest developments, which is why he brought our Eye device to Interoptik Norway, where already many stores are working with the Eye. And Erik has also had our tearcheck device since the beginning of the year to test it out. Before we start with the presentation, so just some general points. The webinar is going to take 1 hour and will consist of a presentation part and the Q&A session afterwards. The presentation will be approximately, I think, 20 to 30 minutes. And afterwards, the rest is dedicated to questions. You can use the Q&A function of Zoom to ask questions, and I will collect them and redirect them then to Petra or Mr. ROBERTSTAD. I would now hand over to Petra for the introduction of the topic.
Yeah, welcome also from my side. It's our great pleasure to have, it's not only our second webinar in our June series, it's also our second webinar today. We had an early morning webinar with the same topic, and now with great pleasure with Erik on board the afternoon webinar. Dry eye diagnostic is a topic definitely, but I think Erik will explain much more details, very important and very interesting in any direction of dry eye management. We as a manufacturer and developer of technologies for dry eye management, we exchanged a lot with the specialists internationally during the last years. And after our treatment technology with EI, which is also very experienced now on the market, we started 2 years ago to develop our own dry eye diagnostic tool. Unfortunately, Corona came during this launch period, but I think with specialists with dry eye specialists like Erik today, who knows already our technology, but who is very, very familiar with different types of diagnostic, what is important for a specialist to satisfy patient, to bring the right therapy to the patient. We considered that, of course, our technology might help. We hope that it will help today, and in days like that when COVID blocked many events and congresses. It's our great pleasure that we have on the podium our well-known KOLs, our experienced users and dry eye specialists, to bring them together with you, being interested in these topics, and to be available for you for any question, of course, regarding on-site our technology. But I would like to hand over directly to Erik to continue or to start with his presentation. And thank you again, Erik, to join our series on webinars. It's not only a great pleasure because you also know us, we know a long time on the dry eye topic, but it's also a great pleasure as we know that many of you are very busy now after Corona. So I know time is money and time is very particular. Okay, so let's start. Thank you, Erik.
Well, thank you for inviting me. It's interesting to talk to such a broad audience from several continents at the same time. It's amazing what we can do with technology. So I suppose you can still see my screen, the first slide, dry eye diagnostic. Is it on, Daniel?
Yeah.
Yeah, yes. That's great. Okay. Diagnostics. So this lecture is totally devoted to how I work and diagnostically with dry eyes, and we'll cover treatment in a later session. And it's interesting because if you listen to different lectures on dry eye diagnostic, you probably will hear some differences, but also some common points. So my goals with a diagnosis is, you want to be sure that we're treating a dry eye, so we want to do a differential diagnosis. But also, my goals are to have a look at severity. I want to know if it's a dry eye, how dry is it? In other words, how on a scale, what's the severity? And I'd like to find out what is the root cause or are the root causes behind the dry eye. And then I'd like to use objective parameters during my workup, so that the more objective parameters I have, the more confident I can be when I follow up. So when I get people back for aftercare or after a series of treatments, I will use the same objective parameters to measure to what extent I was successful or not. But first of all, let's have a short look back at the definition of dry eye. You may be familiar with DYSFUNCTION, and I've just broken up the key elements because it's a long definition of dry eye, but it's a multifactorial disease on the ocular surface. We have a loss of homeostasis to the tear film, and it's followed by symptoms. And those symptoms are tear film, it includes tear film instability, hyperosmolarity, inflammation and damage can occur. Neurosensory abnormalities also very often occur. So these play etiological roles in dry eye. History and symptoms. It's a long list. These are my kind of initial questions. I like to use questionnaires, so I'll come to that in a second. But overall, are your eyes comfortable? I think that is a great question, at least for ordinary eye exams, general eye exams. We use the question, are your eyes comfortable? And let the patient speak when they get that question. If you want to be more specific, you could go, do you ever feel a burning sensation, soreness? Do you ever have gritty or a sandy sensation? Does your vision vary in quality? Some people will report that they see clearer after a blink, or some people will report that their vision is poorer in the afternoon and in the morning, or vice versa. Do they have watery eyes? And if so, is it indoor or outdoor? Are they sensitive to light, dry mouth? We could go on with even more questions. For example, if they have muscle ache or joint ache, stuff like that. But sometimes they can say no to all these things. And then you pop up the question, do you think you have dry eyes? And they say yes. So sometimes the easy question is a good one as well. Do you feel dryness in your eyes? Some people get headaches as well, as you see there on my sort of word cloud. I like to use questionnaires. I like to try and be as objective as possible. So if I'm doing a dry eye exam, which I very often do, I do not like to do a proper diagnosis within the session of an eye exam. If you try to diagnose dry eye properly within the limitations of an ordinary eye exam, where you have to do refraction, posterior retina checkup, pressures, all that kind of stuff, you will not be able to do a good enough job on dry eye. You'll just end up having a poor eye exam and a poor diagnostic workup for dry eyes. So I always like to reschedule the patient for a new appointment, which is a dry eye appointment. And then I would present a questionnaire. I've used all of these three, the DEC5, the SPEED, and the OSDI. The OSDI being the most common one in research. Personally, I prefer the SPEED and the DEC5, and at the moment I'm using SPEED. So I'll probably I'll go on using SPEED for another year or so, and then I'll probably swap to something else. I get interesting stats out of that. But the SPEED is nice and easy to use. So if you don't already have your own that you are comfortable with, you might try it, and it's easily available. So also, I want you to remember the diagnostic dilemma. It's fairly well known in dry eye that sometimes you will get patients with very few signs, very few measurable signs of dry eye or other visible signs, for example, in the slit lamp work. But the symptoms and also the dry eye questionnaire will heavily point you towards this is a dry eye, but you can't see anything. There are no particular signs. And other times you can see a lot of signs of dry eye. For example, you see keratopathy, you see a lot of staining, you see redness, you see all classic signs of dryness, but no symptoms. And this is a dilemma. You have both of those situations can occur quite often, and that is a dilemma. So remember that you will have people who are neurotrophic, so they can't really feel or sense, they don't have a normal sensation. And you will have people who have neuropathy, for example, corneal neuropathy, and they will have lots of symptoms, but sometimes not very many signs. Here's a very common workflow. It's also from DYS2. So we have a presenting patient. The patient can either be asymptomatic with signs or without signs. So if it's asymptomatic, no signs is probably normal. But if he's asymptomatic and we see a lot of signs, then we can think that he is predisposed to dry eye, or that there is neurotrophic or are neurotrophic conditions. Now, if the patient has symptoms, then they can either be with signs again or no signs. So no signs will lead us towards neuropathy, and with signs, we'll have to work those out. So if we work that out on a symptomatic patients with signs, we would like to know, is it aqueous deficient that is the main driver of the dry eye, or is it evaporative, or is it a mix? And more often than not, it is a mix. You will hear different speakers say that 80% is evaporative, it's meibomian gland dysfunction. They may be right, but I'd like you to think about it and don't assume that everyone is evaporative. There can be many causes of dry eyes that will influence how you would treat and whether or not you're successful. So in my workup, here's a kind of an introduction. I will, after I've done my history and symptoms and my questionnaire, I will use a slit lamp. I will have a brief look. I don't want to spend too long time because if I spend a lot of time with the slit lamp, it will influence negatively my measurements. And so I don't want to use too bright light. I don't want to put anything in the eye. I don't want to touch the eye. If I do that, my non-invasive breakup time and other measurements that I will do later on will be invalid. So I want to be careful with the slit lamp. But I'd ask the patient to look down, always have a look at the upper eyelid, have a look at the lids and lashes, see if they look healthy, see if there are signs of blepharitis, look at lid margin redness, conjunctival redness, see if there are any conjunctival folds that are parallel to the eyelids. That's called lip cough. And then I would look at the tear film, see if it's polluted, how does it look generally. Then after having that sort of overview, I would want to do objective measurements. And tear film measurements I reflect on quality, quantity, and stability. Those are the three sort of main things I want to know about the tear film. Quantity is important, obviously. So that's also something you can look at bullet point 1. Have a look at the tear prism. Just a brief look. Does it look short, high, medium, generally? Then we would like to measure it, and I'll come to that. But so that's quantity. Quality, I think non-invasive breakup time will tell us quite a lot about quality. no dry eye measurement will on its own be a diagnosis. We need several measurements that together will bring us to our goal to be confident in the diagnosis. So one single measurement, the specificity and the sensitivity will not be too good. But if you combine them, as my dear friend Luca from Milan has showed us, that if you combine measurements, then the sensitivity and the specificity increases significantly. So we'll measure breakup time, measure the prism height volume to tell us something about the volume, and we'd like to know something about stability and how the lipid layer in the tear film works, because the lipid layer is a key factor in stability. After that, I've still not touched the eye. I haven't touched the eye. I haven't put any vital stains in. So I will seize the opportunity, and I would like to do the first kind of invasive measurement, and that is MMP9 measurement. So I will pull down the lower lid, and I will get my measurement with inflammatory to see whether we have a sign of inflammation or not. And I'll leave those for 10 minutes. It takes 10 minutes to get a good reading, and go on to number 4, which is vital staining. Use fluorescein and listening green. I often combine them, use them together. I use my photo slit lamp to take good sort of base level photos to document. And then last but not least, I will turn my focus to meibomian glands. And then we will evaluate quantity, quality, and possible atrophy of the glands. So the quantity, I use the normal grading system where I push the eyelid either with a Q-tip or with my fingertip, and I'll see how many glands are open when I push. And I evaluate that on a grade from 0 to 3. Some people use other grades, other grading systems. I think they're fine as long as you have a good method. Then I look at the qualities. Is it fluid, transparent, or is it opaque, granular, or like paste-like? After that, I invert the eyelids and I do meibomography. What we want to do, we want to find out what occurs when we do the diagnostic. We want to work out, which parts of this circle, the vicious circle of dry eye, is present in our patient. Evaporative in an unstable tear film, with evaporation, the osmolarity will increase. That will lead to cell damage and cell death. That can create a neural reaction, causing inflammation, releasing cytokines. And one of those biomarkers that is released in inflammation is MMP9. So that's what we pick up there. So we want to find out what factors are involved. And also keep in mind that if we have an inflammation, I will still try to treat it myself. I may not refer for other more advanced treatments. I may try to do it myself. But if I'm not successful, I'll check up on aftercare whether there still is inflammation or not. We may have to consider different options. So working on a slit lamp, anterior eye, general observations. I look at lid margins. Obviously, you want to look at redness, but also are there any bumps or lumps? Bumps, as you see on the left, can be a sign of atrophy. So here we have two bumps, and probably the glands underneath those bumps are atrophied or non-existing. So that when you invert the lid and look at the glands, you will probably see darkness there. On the picture to the right, we have a lump, and you can see a keratinized gland opening. So there's like a lump over there. In my contact lens patients, I often like to remove those lumps with a golf spud because I want all the meibomian glands to work as good as possible. So if I see that some of them are blocked, I will try to fix it. And let's go on. Here's a short video where you can see that it's important to look at also various angles. Well, this is manipulating the eye, so you'd have to do it later on in the exam, but still just showing that angling the eyelids, also the upper eyelid, is important to get good. And here we really need to see that eyelid to know that we have meibomian gland dysfunction. You can actually just see that the glands are fairly blocked. And in addition, we have a lot of redness. It's telangiectasia. It wasn't visible from the outside when the patient looked down, but it is visible now. So have a look at that. Blepharitis will lead to, and when you have biofilm formation, it will severely affect or can create dry eye. You may also have combined blepharitis with various types, probably on the left, as well as Demodex, probably staph. You can see inflamed or dilated vessels going down to the glands, and that's a sign that this is probably not okay. This was a patient who had recurrent corneal inflammations and keratitis, recurrent keratitis. And she was, seeing an ophthalmologist, prescribed antibiotics, maybe 5 times a year, steroids, and it very often just came back after a short time. No wonder when the eyelids look like that. So that's something that we treat and make people understand that this needs to be taken care of by good hygiene. Picture on the right, you have telangiectasia again, as you saw in the video. It's an important sign to note down and to document. And here, conjunctival chalasia often leads to watery eyes, running eyes. It's also has a pretty good correlation with dry eye. So if you see the folds, it's often correlated to dry eye. At this time of the year, at least in Northern Europe, it's probably due to allergy. That you can have folds, but also in dry eye. So I'm marking them here with some black lines just to make it sure. So lip cuff, I would grade that by, if it's 1 fold, it's grade 1. And if you see 2 folds, it's grade 2. Tear breakup time. On the left, you see a photo taken from the tearcheck instrument, just showing lots of redness. It's actually my eye. So now you're seeing me on the screen. So lots of red dots, and that shows us between 2 and 4 seconds, we have a breakup on quite a significant area of that part of the cornea. So you know that the tear film is not particularly stable. And then we have a kind of a stability index on the right hand of the screen, showing kind of micro fluctuations or an unstable tear film. And those are objective measurements. They can be repeated. So you do it again after you've done your therapy and see what happens. And it's a good way of following up the patients. I like objective measurements. It's better to have a computer assessing if it's breaking up or not, rather than you looking in the slit lamp trying to figure it out. Because if you've given a treatment, you will be biased by you wishing wishing for a better result. Tear film quantity. There are various ways. I like to measure the tear prism. In the past, I've also used a lot of Sewn Quick phenol red thread that you put in the lower eyelid, like the picture on the lower right-hand side, and then just measure how much tear fluid is caught by that thread. It's obviously invasive and it tickles, and when you tickle an eye and you get tears, it's not a big surprise. So it's not a really good test for most people, but it can be very useful, because if you tickle an eye and nothing happens, you're not getting any water on that thread, then you know that you have an eye that can't produce much tears. So if you ask them the question, does it ever water when you're outside? If you cycle or go skiing or in the wind, and they say, well, no, my eyes never water. You probably have an aqueous deficient patient. And so it's still useful. Those tests can be useful. Let's go on. MMP9, very easy to use. Lower the eyelid, you take a sample, you dab it 2 to 3 times. Let the patient blink between every time you dab the test. So you've acquired your tear sample and you press 2 parts together and put it in a vial and to moisten the tip, and then you can read off the result after 10 minutes. So if it's positive, we have a red line, and if it's weak, it's a weak kind of inflammation, and if it's a strong red line, it's a higher degree of inflammation. A lot of people would say, well, I would know when I put fluorescent in, I see a lot of staining, we have inflammation. And that's kind of the classic or maybe old-fashioned way of thinking about inflammation. But what we see is that you can actually have quite a lot of staining in the corneal epithelium without getting a positive MMP9. And sometimes you can have a complete mirror, no staining at all in the cornea, and you still have a positive MMP9 measurement. So it's not that clear cut. I like it because it's objective. Again, you can repeat it after some weeks or some months and see whether your treatment has had the effect that you wished for. So after that, we're on to vital staining. As I said, I like to use both lissamine green and fluorescent, because lissamine green is good to look at the lid wiper epitheliopathy and lid margins. And also it's really creates sometimes really nice photos. So it's easy to show to the patient that their eye is staining and is sore, and it makes people understand. So, and I don't grade staining. You can use Oxford grading, look that up if you want to grade it. I take photos and I use that for comparison. If we see staining inferiorly, just keep in mind that that can be due to either blepharitis again, or it can be due to incomplete blinking, or it can be due to lagophthalmos. So maybe nocturnal lagophthalmos people, if people aren't closing their eyes at night, you will never be able to get a good solution if you don't find that out. Meibomian gland dysfunction. So we have vanilla on the right. It's the most common kind of root cause of dry eye. Again, I think with meibomian gland dysfunction, just keep in mind again, if you take 10 people off the street, take them into your eye exam room, squeeze your eye, have a look at the grading of the meibomian gland, you will probably find quite many of those 10 will have meibomian gland dysfunction. And again, going back to symptoms, very few of them will have symptoms. If you do your contact lens patients, squeeze all your contact lens patients, you will see, again, you will see a lot of meibomian gland dysfunction. But their contact lenses are comfortable. If you ask them, they say, well, I wear contacts, I do wear them every day, I don't get problems, I take them off before I go to bed. And you go, how is that? Why can that be? We obviously see they have meibomian gland dysfunction. So it's just to keep in mind that more often than not, there are several factors contributing to a dry eye. And meibomian gland dysfunction, again, on its own, be careful to jump to a conclusion. But you grade it on quantity. Remember that you're supposed to squeeze the lid for 10 seconds. It's much longer than what people think. So it's after 10 seconds, then you can judge how many of those glands actually opened. And that's the basis for your grading. On quality, you're supposed to grade 8 of those central glands on quality. So we look for a clear fluid, opaque, granular, creamy, and then pasty looking quality. After this, I do meibomography. And here's an example again, using the tearcheck, where we see the infrared photos on the top, and then we see the computerized sort of interpretation of that. on the bottom. And it's quite cool, and it estimates the loss of glands, and it's good documentation. And it's vital to do this before some of the treatments that we offer. For example, if we're going to treat meibomian gland dysfunction with IPL or manual expression or other methods, we want to make sure that they actually have glands. Because if there are no glands, then there's no point of offering a time-consuming treatment. And also, if there is a significant loss, you want to set the expectations right. So you don't want the patient to be too optimistic about the result if there are very few glands left. So you might have good reasons to take care of those glands, but set realistic goals. Here's my colleague's Heiko Pult's MEIBO scale. You might have seen this before. It's just to give you an idea of what we're looking for. So again, I'd like to do objective measurements and get an objective measurement, but you can also use a kind of a grading system if you want. This is a test that I also include, particularly if you see inferior staining. It's a good thing to do. You ask the patient to close their eyes. Don't say anything. Turn the light off in the room. Ask the patient to close their eye like this. And then you go with a torch. You can probably use your pen torch. I have one like this that is slightly curved. And I switch it on and close eyes, put the torch on the eyelid. And just try to get the patient to relax and close their eyes. Then you bend down and you look from underneath if the light is sieving out between the lids. So if the light sieves out, you know that you do not have a seal, and you want to have a seal when people close their eyes. It's amazing. You should think that this happens very often, but you go ahead. If you take one take-home message from today, you do this test, it will be a winner. You will help so many people just by doing this. And if they have a poor lid seal, you can think about nocturnal treatment, like wearing a mask when sleeping, put an ointment in at night, various methods. Forgot myself there. I was not supposed to talk about treatment. So we'll cover that next week. All right, diagnosis. We're gonna try and sum everything up and come to a conclusion. So you look at your results, look at all your objective measurements, look at the symptoms, the questionnaire, make up your mind. How kind of, are we on the aqueous side, or are we on the evaporative side, or is it a mix? And if it's a mix, is it kind of right in the middle, or is it more towards evaporative, more towards aqueous deficient? So that's how I think. Where is the scale tipping? And also, if you have very few signs, be aware of neuropathy. You might do the treatment, everything, blah, 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 if you know you have classic symptoms of dry eye and very few signs. Watery eyes, are they always dry? Some people think that watery eyes are always dry. I have to disappoint you, it's not always the case. You will know both in Canada and Australia too, you have, for example, allergy that can create watery eyes, conjunctival chalasis that can come with allergy, but it can also be a thing on its own. Lid margins, have a careful look at lid margins if they are properly aligned and facing inwards so that it will lead tear fluid towards the punctum. If there is an ectropion, that will make the whole blinking process not working very well. If it could be as simple as a stenosis in the lacrimal drainage system. So if you have a stenosis, then obviously your eyes will water. They will often water both indoors and outdoors. So that's an important question to ask. So if in doubt, I always flush. I do lacrimal syringing with just sterile water and flush through to make sure that I know that my lacrimal drainage system is open. Rather than wasting too much time on other treatments. This is one of the last slides. I'm not going to talk about therapy, but this is another differential diagnosis. It's useful to look at. When you invert the lower eyelids and the upper eyelids, you may see concretions. And concretions can actually give you sore eyes. They can give you foreign body sensation, sandy feeling. So it can kind of sort of be a dry eye in disguise. And if they're not staining, it's probably okay to leave them. But if they are staining like this one, you see with fluorescein that they take the fluorescein and stain up. You can be very successful if you remove those concretions, and it can be really a big relief for some patients. Okay, to round off, here's a couple of photos, same patient, same eye, and it's how long time is it? It's almost 3 months, in between. And you can see a clearly visible difference between those two. And I'll tell you next week how you can achieve this result. So that's coming soon. If you have questions, please ask. Thank you.
Do you think that with a real and regular dry eye diagnostic, you can avoid or you can make you can set up a kind of prevention for your patients also, if they know in early stage about their loss of function symptoms or something like that? Is it possible to educate patients on this point?
I think it's possible, but it's difficult, because if people feel no pain, they will not be really convinced to do anything about it. So you would have to really use, I think meibomography is probably our best tool so far to show if you can show significant atrophy, you can say, well, you're not having any pain because you have 40% of your meibomian glands left. You've lost 60, you have 40 left, and you won't have any symptoms because you have that. But if that goes down to like 20, you're going to have big symptoms. So I've found out that may work, and people will actually understand that. So that's a good opportunity. The other opportunity is the big group of contact lens patients we have. And I think, that's one of our focus areas for this fall and next year for us, is to really work harder with our contact lens patients. And to be proactive and to treat more of them also, to improve their comfort and their comfortable wear time. Because for sure, comfortable wear time can be increased, even if people say, well, I don't have any problems. I remove my lenses at 6 o'clock every night and I put my glasses on and I'm fine. But if you punch a little bit harder, you will find out that they are not 100% satisfied, and we can work, we can improve that.
Thank you for all the answers. It's almost 5, I think. Yeah. Before we end the session, maybe we have some questions left then. I would like to remind everyone about our upcoming webinars next week. Next week, we have 2 time slots as well, one at 8 a.m. and one at 4 p.m. Central European time. The webinar will be about best practice with the EI treatment. In the morning session, we will have Professor Dr. Jennifer Craig with us. And in the afternoon session, we will again welcome Erik ROBERTSTAD. And in 2 weeks' time, we have a webinar about the future of dry eye management. Here also we have 2 time slots. In the morning session, we will welcome back Dr. Luca Vigo from Coronas Vision in Italy. And in the afternoon, we will again welcome back Erik ROBERTSTAD from Interoptik Norway.